Bariatric surgery, often considered a last resort intervention for severe obesity, is now being recognized for a benefit that extends far beyond weight loss, a significant reduction in cancer risk and mortality. While lifestyle changes remain the cornerstone of obesity management, emerging research suggests that for individuals with clinically severe obesity, surgical intervention may offer a powerful defense against some of the most aggressive, obesity-linked cancers. This is not just a side effect of weight loss. It's a reflection of deep physiological changes that occur when the chronic metabolic stress of obesity is relieved. Several large-scale observational studies have demonstrated that individuals who undergo bariatric surgery, such as gastric bypass or sleeve gastrectomy, experience a measurable reduction in cancer incidence and mortality, especially among women. These procedures are associated with a sustained drop in systemic inflammation, improved insulin sensitivity, and a rapid shift in hormone levels, including reductions in circulating estrogen and leptin, both of which are implicated in the development of breast, endometrial, and pancreatic cancers. As fat tissue shrinks, so does its role as an endocrine organ that fuels carcinogenic processes. This benefit is particularly notable given the challenges of achieving and maintaining significant weight loss through non-surgical methods in individuals with long-standing, morbid obesity. Bariatric surgery induces rapid and often durable metabolic changes that go beyond calorie restriction. Within weeks, patients may experience lowered levels of pro-inflammatory cytokines and improved gut hormone profiles, both of which can dramatically reduce cancer-promoting environments at the cellular level. In short, the surgery doesn't just shrink the body, it reshapes its internal chemistry in ways that make cancer less likely to take hold or progress. However, it's important to approach this data with caution. While the evidence linking bariatric surgery to reduced cancer risk is promising, it's not definitive. Most of the research is observational and cannot fully rule out confounding factors. People who undergo surgery are often highly motivated, closely monitored, and may make other health-improving changes that contribute to their lower cancer rates. There's also the possibility of selection bias. Those chosen for surgery may already differ in significant ways from those who are not referred. Long-term randomized trials are difficult to conduct in this population, and ethical constraints limit how such studies can be designed. Moreover, bariatric surgery is not without risks. Complications can include nutritional deficiencies, surgical complications, and long-term gastrointestinal issues. Mental health challenges such as depression and disordered eating can also persist or emerge post-surgery. For some patients, the physical transformation does not automatically resolve the emotional or behavioral patterns that contributed to obesity in the first place. And access to surgery remains unequal, with low-income and minority patients facing more barriers in terms of cost, referrals, insurance coverage, and follow-up care, despite these same populations often facing the highest burden of obesity-related disease. It's also worth noting that surgery does not eliminate cancer risk entirely. Patients still require appropriate screening and long-term health monitoring, particularly for cancers not strongly tied to obesity. And because bariatric procedures vary in technique and intensity, the protective effect may differ depending on the type of surgery performed. Gastric bypass, for example, may offer greater metabolic benefits than gastric banding, but also carries higher surgical risks. Despite these caveats, the link between bariatric surgery and reduced cancer mortality highlights the importance of treating obesity not just as a cosmetic or a lifestyle issue, but as a serious, chronic medical condition with far-reaching implications. When conservative approaches fail, surgery may offer a life-extending option, especially for individuals at high risk of developing obesity-linked cancers. Still, it must be pursued within a framework of informed decision-making, comprehensive care, and long-term follow-up, rather than seen as a quick fix or universal solution. In the end, bariatric surgery should be understood as a tool, not a cure. Its impact on cancer mortality reinforces the urgency of recognizing obesity as a critical factor in cancer prevention, while also raising difficult questions about access, equity, and the limitations of non-surgical treatment. For those who meet clinical criteria and have exhausted other options, it may offer more than weight loss. It may offer a second chance at life.